하나, 둘, 셋.
Hello. Easy orthodontics with a cup of coffee. I am Ortho Barista Dr. G. Dae-kyung.
I am Ortho Barista Dr. Lee Jong-kuk.
Today, we'll learn about simple orthodontics for slightly misaligned front teeth. But before that,
커피 한잔 할래요?
The orthodontist barista's coffee recommendation for today is Tata, Greek Frappe.
are we going to Greece this time? Greek Frappe is also known as the most popular coffee in Greece. It's easy to make by mixing instant coffee and water, so it would be nice if we could make it together. First, take 2 sachets of mixed coffee that you can easily get and put it in first. Then, add brown sugar as much as possible. 4 spoons will be fine. Add cold water. After that, you can continue stirring it with a blender.
Oh, this comes out right away.
Automatic is great. I got nervous thinking if we're playing rock, paper, scissors since I did lose and told to do it by hand. Do you know the origin of the Greek Frappe?
It was created by a Nescafe employee in Greece's second largest city. At the international trade fair held in Thessaloniki, they wanted to serve instant coffee, but since it's Greece, there wasn't any hot water, right? So, they used a shaker to mix instant coffee with cold water, and that's how the Greek Frappe was born.
Oh, nice job.
Why can't you do it?
Could you please try using another one?
Oh, it works well now.
It must just be a difference in machines. Unintentionally, I teased you.
Now, let's go ahead and add some ice. And I'll pour in some milk. The way it spreads feels a bit different from the Portuguese coffee cocktail we made before. Would you like to give it a taste?
Oh, this is delicious.
Out of the 8 times I've made it, this is the best one. What do you think personally? It's smooth, milky, soft, and sweet. Definitely something.
I'd recommend.
Does it represent our brotherhood? All right, let's officially begin Lee Jong-kuk and G. Dae-kyung's Easy Orthodontics.
For those of you watching the broadcast on Denol website, feel free to send in your questions through the chat, and we'll do our best to answer them, and we'll be giving away Starbucks coupons through a random draw.
Before starting partial orthodontic treatment, there are several factors to consider. One of the things I've often been asked about when performing partial orthodontics is, hey, just go easy on it. There are a lot of side effects. While it may seem like a simple approach, on the other hand, there are quite a few considerations that make it not so easy.
There really are many things to think about.
From a broader perspective of alignment, factors like the amount of crowding and the degree of rotation need to be considered. For instance, when performing partial orthodontic treatment on the lower teeth, there are cases where the mandible shifts forward significantly. CRCO discrepancy or occlusal temporomandibular joint issues are critical factors to consider. Today, we'll discuss these considerations while also reviewing some of Dr. Jong-kuk's remarkable cases. Let's take a look at an example from clear aligner treatment. Before that, there are various classifications for partial orthodontic treatment on the front teeth. Today, we've divided it into clear aligners, labial brackets, and lingual brackets. Typically, we use traditional bracket treatments like straight brackets or self-ligating brackets, but we can also proceed with simpler options such as tube-type MTA brackets or I-tubes. Additionally, multifunctional brackets like A1 bracket are becoming more common. Sometimes, I reflect on this. About 15 or 16 years ago, I had cases where patients experienced a slight relapse or needed something simple addressed. In these cases, using full brackets felt a bit excessive.
이런 경우에 네.
And many patients didn't want them either.
그래서
That's true.
지금 팁이라고 말씀드리긴 좀 어렵지만 우리
So, while I wouldn't call it a tip, you know the large syringes?
그거를 잘라서
I've actually cut the needle part off and used it as a makeshift tube in some cases.
진짜
I've heard about it.
Oh, yeah. Was it a long ago?
There was no device like that at that time.
Also, since it is a partial orthodontic treatment, there is a desire to make it as less visible as possible from the patient's point of view. So, rhodium-coated wire and general coating wire are used a lot, but I don't know if rhodium coating wire is still available these days.
The wire I used has been discontinued. However, you can purchase it if you would like.
제가 이제 쓰는 코팅 와이어는 아직도
The coated wires I use are still in use, but since they tend to peel off quite a bit, there are pros and cons, including increased friction.
뭐 장단점이 좀 있는
Rhodium wires, on the other hand, barely peel off, which is a great advantage. However, I've noticed that even rhodium wires can peel to some extent, but it's not that noticeable. I think it's good.
Anyway, it's useful. When we look at the chat window, we end up using the live chat for the entire 30 minutes, and wow, both hands are really busy, right?
Yes, truly busy.
So today, I will be a questioner as much as I can, and I will try my best to solve your curiosity.
하도록 하겠습니다.
Generally, when we talk about partial orthodontics, it can refer to attaching partial orthodontic appliances. Since they are relatively small and comfortable for the patient, there are even cases where some people use partial appliances for full orthodontic treatment. I've come across many good cases like that as well. But today, we'll focus on treating misaligned teeth or malocclusions limited to the front teeth. First of all, there needs to be a standard, and usually, the canines serve as the reference point. The treatment is centered on arranging the four incisors in front of the canines. So typically, this diagram represents what we need to consider, working from canine to canine. Assuming that the canines remain mostly stationary, the most important aspect is how to arrange teeth number 1 and number 2. This ties back to what we discussed last time, or rather, 2 sessions ago. As I mentioned in the clear aligner discussion, you need to decide on the alignment line for straightening teeth. This applies not only to clear aligners but also to partial orthodontics. So, the key focus is how to adjust the size and arrange the 4 front teeth from canine to canine. If adjusting the size still doesn't achieve proper alignment, then other methods need to be considered. Partial orthodontics might not be sufficient, or, in some cases, extracting one tooth could be an option. However, extracting an upper tooth isn't typically done, so in the case of the mandible, there are situations where extraction is part of the treatment. The main framework to consider is how to arrange teeth number 1 and number 2 within the space between the canines. There are cases where patients only want to straighten those 4 front teeth. Key considerations include factors like the temporomandibular joint condition, occlusion, and whether everything else is acceptable, with only that area requiring correction. If that determination is made, the first question to address is whether it is truly possible to straighten all the teeth within the space between the canines. This is the most important issue to think about.
When patients come in for partial orthodontics, one of the most common questions they have is, will it be faster? This seems to be a significant concern for many.
Personally, I do think that partial orthodontics is definitely faster compared to full orthodontic treatment. First of all, since the brackets and tubes are very close to the teeth, I think it's definitely more effective for precise tooth movement compared to traditional braces. The first advantage of partial orthodontics is that the appliance is closely adhered to the tooth surface. Secondly, since stripping can be performed immediately, tooth movement can occur right away. In contrast, with traditional braces, depending on the case, teeth might need to be distalized or expanded before alignment can happen, so the process isn't as immediate. In partial orthodontics, such additional steps aren't possible, so teeth begin to align as soon as space becomes available. Another benefit is the use of tubes, which facilitate low friction, low force movements, making tooth movement more efficient.
That said, there are cases where partial orthodontics takes as long as full orthodontic treatment, depending on the situation.
Exactly, unexpected tooth movements are probably the most critical factor to consider.
For instance, Partial orthodontics might end up transitioning into full orthodontics in some cases. There's also what's known as phantom crowding. In such cases, even full orthodontic treatment can take longer than anticipated. This highlights the importance of careful case selection when planning treatment. Choosing the right approach for each individual case is essential to achieve effective and timely results.
Actually, I think diagnosis is very important. It's essential to check if there are any other issues beyond the front teeth. The next step is deciding how to arrange them and establishing the reference point for alignment. This should always be the first step in the process. If we really want to break it down, we could consider those two lines as possible alignment options. The question is whether we should align based on the black line or the red line. These decisions should prioritize aesthetic considerations and how they relate to the overall facial profile. So, when we choose to align according to the red line, the next step is to assess whether it's actually possible to achieve the desired alignment based on that reference point. So, these steps can be easily assessed with a well-taken 90-degree intraoral photo. You can then draw it in PowerPoint and set up potential treatment plans. For example, you could try visualizing the alignment, whether extraction or non-extraction is needed. In cases requiring extraction, stripping might be necessary to reduce the size of the teeth. By reducing the tooth sizes and testing different configurations, you can get an idea of how the teeth will align. This method of planning is likely the first step in partial orthodontic diagnosis. So, let me first show you the simplest and most commonly encountered case in clinical practice. This is a very typical case. Of course, before proceeding, it's essential to make sure there are no major issues with the occlusion or other diagnostic factors. Once that's confirmed, we can move forward with the treatment plan. Let's discuss how the process unfolds. I took photos at 1-month intervals. The appliance was attached about a month ago. Of course, IPR stripping was done first. Then, we continue monitoring the progress over the next 2, 3, and 4 months. So, of course, not every case will follow this pattern, and I'll explain more about that later. However, with these expectations in mind, we can proceed with the treatment. Looking at the progress after 1, 2, 3, and 4 months, if the patient receives treatment in this manner and it's successful, it could be one of the best treatment options.
This kind of tooth movement can also be an indication for clear aligners, especially for dentists who have just started orthodontic treatment.
Should we choose clear aligners or partial orthodontics? This is definitely something that could come up in the chat.
Yes, it could be partial clear aligners.
For those who are concerned about the cost, some patients prefer the traditional appliance. On the other hand, individuals who prefer minimal visibility for professional reasons or personal preference tend to opt for clear aligners. Now, for the second case, for example, extracting one tooth from the mandible may be necessary to achieve proper balance. Assuming everything else is fine, cases like this can actually be encountered quite often in clinical practice. When we come across such cases, we can sometimes start by doing pre-treatment stripping to help align the teeth and create space. For example, if we determine that the alignment can be achieved with just one tooth extraction, we may proceed with extraction-based treatment. However, there is often some concern when it comes to mandible extraction.
Yes, there are concerns about the defect area filling with bone, especially in cases with significant crowding, where tipping might occur. When there's a lot of tipping, it's important to consider whether root movement will happen effectively.
As you mentioned, extracting a tooth should always be a well-thought-out decision.
The Bolton ratio should be carefully assessed,
and the treatment should proceed based on that consideration. In this case, we have 3 options, and after extracting one tooth and adjusting the alignment, we can observe the progress. If we look at the overjet, we can evaluate movement and whether the treatment is progressing as expected. Looking at the overjet, if we align based on number 31 and number 42, it could lead to some edge bite issues, which would require inward adjustments. This might necessitate more stripping than we'd want to avoid extraction. However, when we proceed with extraction and realign the teeth, we see that aligning based on number 32 works well. The size adjustment seems good, and it's acceptable, so we decide to extract one tooth. My concern is whether extracting a front tooth will allow us to address the defect. While there are many factors to consider, this patient is young. And there aren't significant issues with the gums, so I'll move forward with the treatment and show you the progress. As you can see, even though there's a slight resin buildup, the outcome is quite promising. There's no noticeable sign of the extracted tooth, and the alveolar bone shape and root movement are progressing as expected. This case demonstrates that even with partial orthodontics, we can expect some level of root movement and changes in inclination, which is a positive outcome for this type of treatment.
When dealing with significant incisal inclination, such as in cases of fan-type crowding, it's true that even full orthodontics can struggle with smooth root movement.
In these situations, the teeth often remain tilted. Regarding the tip for such cases, one strategy is to extend the appliance from just the canines to the premolars. The key strategy is to maximize anchor points wherever possible. In this case, I intentionally placed the brackets at a slight angle, specifically rotating them counterclockwise just a little bit. If you try to rotate too much all at once, you risk creating a reaction force, so it's important to proceed gradually. It's easier to adjust the brackets slightly, adding and removing pressure incrementally. For this patient, this approach of gradual adjustment and careful bracket positioning is likely one of the most important tips.
Another potential method, though it might look a bit messy, would be to add a lingual button on the lower side of the tube bracket and connect it with a power chain to create a slight moment force.
This could help with aligning the teeth, though it may not look aesthetically clean. However, it's a good tip for improving efficiency and movement. Overall, carefully managing these aspects is essential for achieving a successful outcome.
There are definitely many considerations to keep in mind. For example, the reaction forces on the posterior teeth are important. When we talk about the posterior teeth, this doesn't just include the canines, but also rotated teeth and their interactions with adjacent teeth. There may be some considerations when bonding, and when it doesn't work out, how can there be additional approaches and considerations for antagonists? Therefore, in terms of considering the reaction of the rearmost tooth, if the rotation is in different directions from each other in these two, such a wire is added, this reaction occurs. Personally, I can see this from two aspects, and this way, the canine expands like this, so there is one thing that breaks the occlusal surface of the canine and premolar area. Secondly, it is about the period of treatment for the teeth number 41 and number 31 in the anterior region. Personally, in that case, it takes a little longer for engagement. Basically, stripping is performed, IPR is done, and the appliance is first attached to only one of the rotated anterior teeth. After rotating the initially treated tooth, you move on to the adjacent tooth. If number 31 was treated first, then proceed to number 41, or if number 41 was treated first, then move to number 31. Progressing in this way can make the process a bit faster.
And this tip may also be applicable in bracket orthodontics. As seen here, splinting is used to prevent the reaction force on the posterior teeth. While it might not be extremely common, it is a useful approach if reaction forces are anticipated. Regularly monitoring and addressing such forces as needed is key. For those attempting partial orthodontics for the first time, considering these factors and incorporating them into your routine could be very beneficial. In fact, when it comes to bonding, the irregular alignment of teeth can make it challenging to attach appliances, as previously mentioned. So, how should it be done in such situations? First, there are scenarios where bonding cannot be achieved. In such cases, it would be difficult to bond to certain teeth. For example, if you bond to this tooth, the wire likely won't fit properly. So, what should you do in such situations? Here's my approach. Bond to as many suitable spots as possible first, and then adjust gradually over time. What does this mean? Initially, you attach the appliance in places where bonding is feasible. In some cases, you might skip certain teeth entirely at the beginning. However, to encourage even minimal tooth movement, you bond where you can. Then, as the teeth start to move slightly, you can reattach or adjust the bonding accordingly. That's a way to approach. The second way is if we attach a partial orthodontic appliance. First, bond where possible, even if it's challenging to engage the wire at certain angles. You can do it with some skill, but there's a method that involves using a small device.
Like a mini tube?
Yes, it might fall off sometimes, but you can attach the small device first and then replace it when needed. The third way in cases where the teeth are so rotated that bonding a bracket is not feasible. Once the wire reaches the rotated tooth, insert a tube attachment onto the wire. Bond the tube while pressing it against the tooth surface, even if the fit isn't perfect at first. By pressing and attaching the brackets first, you can achieve efficient bonding compared to attaching them after placing the wire.
For this to work smoothly, using a lighter wire size is key.
This approach is typically applied in the initial stages of treatment. What size of wire do you use initially?
I personally use a 010 wire. Sometimes, I opt for thermo nai-tai, as it offers even more flexibility than traditional nai-tai.
It's because of the high price.
Yes, it's very expensive.
Because it's expensive, I don't use it as a general concept, but for good results, I do use it quite a lot. So, this is how it progresses. I've shared 3 points, and now I'll talk about the key aspects of canine bonding.
자, 첫 번째 줄 보면은
너무 맛있어서.
아, 네. 우리 같이.
First, depending on whether the partial orthodontics includes the canine or not, it could involve the canine or the premolars. Generally, I talk based on the assumption that brackets are placed from canine to canine, with the assumption of placing tubes as well. The canine should not move. The condition is that it should not move, and that's the basis for my explanation. So, canine bonding should be done passively. And when looking at the occlusal surface, the appliances should be placed symmetrically in parallel to each other. Typically, when we attach brackets, we place them parallel to the long axis of the canine and twist them slightly. If we attach them ideally, when the wire is inserted, the front teeth will all move upwards. Definitely not in an ideal position, but in a passive position. We can still estimate it to some extent. Depending on the position of the bracket or tube on the canine, it should be placed in a direction that doesn't affect the vertical position of the front teeth. That's the first point.
Even if there is crowding in the posterior teeth, when we perform passive bracket placement according to textbooks, I'm sure many of you are already familiar with it. You can apply that knowledge.
If using indirect bonding, that concern is eliminated because the brackets are pre-made and placed. When placing them in the clinic, check the height of the opposite canine before curing, because this can be placed slightly higher on one side. Always confirm the height on both sides before curing, otherwise, an asymmetrical shape may appear. Also, as I mentioned earlier, the canine should not move using a splint, it needs to remain stationary. And finally, whether the canine is symmetrical or asymmetrical in relation to the occlusal plane. What does this mean? If we look at it, the direction of the canine is like this, and the left and right are slightly different. Since the degree of rotation differs between the left and right sides, if we just bond the brackets like this without considering it, the arch may get distorted. Since the canine should be placed passively, we need to consider symmetry. If we were to consider it here, we could place the tube of number 23 slightly more forward to align with the other side, or place it slightly more backward to match number 20. However, if we place it too far back, the teeth will protrude, so we need to consider this and place it at an appropriate position. This is a clinical tip.
When orthodontists give lectures on partial orthodontics, I believe they always point this out. Not considering these things during partial orthodontics can lead to a distorted arch.
Of course, even when we place brackets, at the beginning, the arch may become more distorted, and in such cases, we often rebond after adjusting the placement. Next, we will definitely encounter cases where, even though we carefully placed the brackets in the correct position, the teeth do not move or do not move as expected. This is quite common. In such cases, we can perform wire bending. You might think, but this isn't a bracket, how can we do wire bending? However, even within the oral cavity, when there is a wire in place, we can apply wire bending, but it must be done very carefully in a vertical direction. This is called a light wire flyer, and it would look something like this. That's right, this is the beg technique where we apply bending vertically from the occlusal view inside the oral cavity. By bending it like this, the teeth will move accordingly. These are cases where direct bending is done within the oral cavity. However, it's important to be cautious. If the bending isn't done vertically from the occlusal view, it can cause issues with vertical movement. You have to ensure the alignment is correct, but this is something to be aware of. In cases where the teeth are misaligned and you want to adjust them at the final stage, this type of bending can help correct the position. It's not something that must be done, but if the teeth aren't moving as expected, a slight adjustment can be made. Just keep in mind that the appliance could come off during this process. So any protruding parts need to be held in place manually as you twist them. Light wire can also be deformed like this.
You can hold both sides like this.
However, it seems like you only need to hold the protruding part. Since it's in the direction of being compressed, it doesn't tend to fall off easily, but it's usually fine to hold just the side that's protruding. Even though we placed the wire for partial orthodontics as instructed, let's take a look at this patient. What happened? If we look at tooth number 11, it needed more counterclockwise rotation. I tried fixing it, but despite bending and other adjustments, it wasn't rotating properly. So how did I rotate it? This is actually a clinical tip. When looking at tooth number 11, after removing the appliance, we make the distal base of base 1 quite thick. When bonding is done, it compensates to some extent. If the rotation isn't adjusting well, you can try adjusting the base thickness to help rotate it. I think this is one clinical tip.
You need to be careful with the adjustments, as you don't want the thickness to be too much.
But the rotation can be adjusted a bit more. Lastly, as mentioned earlier, it's also an option to not attach one bracket and leave it open. In my case, I attach a lingual button on the lingual side and use a power chain. Then, it's often very easy to adjust the rotation using this method.
It's a good approach.
When there's a V-shape, I routinely attach it on the lingual side. However, if the vertical height doesn't match, tipping can occur. So it's important to attach it at the same height for the teeth to align properly. This is one clinical tip that can be applied directly in practice.
Anyway, in those cases where pulling doesn't work, you must check if there is space around the teeth.
If there is no space, it seems that the teeth won't align properly.
It's better to think that there is no tooth movement in areas where there is no space. It's delicious.
Can't stop drinking. As I mentioned earlier, this may be the best coffee I've had during this whole 8 lectures, definitely my taste.
I feel the same way. It's the best coffee, so I keep drinking it. Up until now, Dr. Lee Jong-kook has explained many clinical tips regarding treatment during partial orthodontics. First, the state of the posterior molars or the teeth where action and reaction forces are applied. Second, tips on how to make teeth move if they are not moving easily, considering the antagonist. Additionally, considerations during bonding, especially with canines, which should not move and should be passively bracketed. These are very useful tips, especially when doing posterior partial orthodontics, so it would be good to keep them in mind. I hope you found the tips on anterior partial orthodontics helpful. Depending on the perspective of different orthodontists, there might be some controversy or other biases, but in clinical practice, there are actually quite a few patients who seek to improve the aesthetics of the anterior teeth while maintaining good posterior occlusion. Dr. Jungkook has provided very useful clinical tips today, and I hope you have the opportunity to apply them. Next time will be our 9th orthodontic lecture, What to be careful about. Next time, what to be careful about. The slogan is,
If you do it in advance, you won't regret it later. If we had said it earlier, there wouldn't be any complaints later. But sometimes, after the fact, it may become an excuse for issues like black triangles or other side effects.
in orthodontic treatment, we spend a long time with patients, and while relationships can improve, sometimes small issues can lead to misunderstandings. In that regard, we will be introducing various troubleshooting aspects to you. I hope you enjoyed today's session with a milky, soft, and sweet coffee. This was Ortho Barista. I hope you had a pleasant time, and we look forward to seeing you on July 5th. Thank you.